Amitava introduce? I mean, this will be good. Yeah, carry on.
Like you can start the session like that.
Let him start and introduce also.
Okay, yeah. So should I?
Yeah, please start.
Yeah. Okay, so it's really nice to be back on.
Sir, just a second, sir. Just. We are live.
Good evening, everybody. It's really great to be back with the iFocus online lecture series. And this is the 10th in the lineup with the Squint and Paediatric Ophthalmology. And we have Dr. Sumitha Muthu from Narayana, Nethralaya, Bangalore, who will be talking about the basics and theories of binocular vision and stereopsis. A little background about Dr. Muthu. She's currently working as a consultant in pediatric ophthalmology and strabismus at Narayana Nethralaya. Her basic medical education has been from the JJMMC Devangiri, and she's interned and tutored at the CMC Vellore. Her post-graduation was conducted at Bangalore Medical College and Research Institute, and she's done a fellowship in pediatric ophthalmology and strabismus from Narayana Nethralaya. Her areas of interest include paralytic squints, syndromic association in eyes diseases, congenital and developmental cataracts, non-strabismic binocular vision anomalies, childhood myopia, and neuro-ophthalmology. So over to you, Dr. Sumitha Muthu, for today's session.
I'll just take 1 second of yours. I would like to welcome Dr. Pradeep Sharma as a chair and Dr. Amitava. And we can also see that Dr. Meenakshi Swaminathan has also joined us as a co-chair. Welcome all. Over to you, ma'am, Dr. Sumita.
Thank you so much, Amitava sir, for the kind introduction. And it's really a pleasure actually presenting in front of doyens in this field. And I also would like to thank Dr. Santosh and Dr. Pradeep Sharma for especially for giving me this opportunity. Thank you so much. So I hope you can see my slides.
Yes.
Yeah. So I understand this is for
slideshow.
I've kept it as simple as possible. And so today we are going to discuss about binocular vision under the following headings: a little bit of introduction and how binocular vision evolved. These are just some interesting facts, maybe not the must-know facts, just some interesting facts about binocular vision, and some various terminologies which are used and various aspects of binocular vision. We'll not be discussing about anomalies of binocular vision in detail, just a few of them. And so as you all know, vision began as single cells which can actually perceive or sense light. And later, of course, in the evolution came a complex organ such as the eye. And so as mutations occurred in various species to satisfy various needs. So for example, this video shows a prey and a predator. So a prey such as a rabbit requires excellent binocular vision because it needs to see the predator coming on the side. Whereas a predator such as an eagle requires excellent stereopsis and excellent localization so that it can accurately reach the prey and grab it at a fraction of a second. So a wider binocular vision, field of vision is imperative for a prey, whereas a better stereopsis is something that predators require. So if you look at primates and man, what have we traded off for? We have traded off the binocular field of vision for better stereo vision, better color vision, better visual acuity. Of course, we had to compromise on the field of vision. So binocular vision, basically by definition, is something that enables us to fuse the images from two eyes and perceive it as a single three-dimensional image. So before we move on to binocular vision per se, we must know that every visual stimulus actually has the following characteristics: brightness, form, color, and direction. So what is direction? So basically, it is the direction at which we perceive that visual stimulus. For this, we can do a simple experiment. This is, of course, quoted in the von Nuden's book. And what you can do is press on an eyeball, and then you will see a black spot, okay, in the space that you're visualizing, in the visual space. So this is basically the direction. So this point on the temporal retina is actually projected at that particular area in the visual space. And this is the direction of that particular point on the retina. So this is one of the characteristics of visual stimulus. So we need to know about visual direction and corresponding retinal points. This is very important in understanding the theories behind binocular vision. Okay, as you can see here, when we are looking at a target here, the circle here, the target which is on the right hand side, this triangle is visualized by the nasal point on retina and a temporal point on the retina in the left eye. So nasal point in the right eye and the temporal point in the left eye are actually corresponding retinal points because they have the common visual direction. So same here. This temporal point in the retina in the right eye and nasal point in the retina in the left eye actually visualize this square object while the patient is actually focusing, while a person is actually focusing on this target here. So there are various corresponding retinal points in both the eyes, and these can actually vary as well depending on the position of the eye. So there is principal visual direction, which is actually the visual direction of both the fovea, and secondary visual directions, which are actually the visual directions of all the other corresponding retinal points. So we need to know about horopters and Panem's fusional area. So horopter is basically, the loci of all the corresponding retinal points, and for a particular fixation distance is actually combined together, and that gives rise to the horopter. And you have Panem's fusional area, in which all the objects within the Panem's fusional area are actually perceived as one, and the objects which are beyond the Panem's fusional area are actually perceived as two images. So you find uncrossed disparity when it is beyond the Panem's fusional area, and there is cross disparity or crossed diplopia when the objects are in front of the Panem's fusional area. This, of course, all of you know, this is what causes the physiological diplopia, and we actually neglect physiological diplopia. We don't appreciate it all the time because we don't perceive that our concentration is on the fixation target. For example, if you're looking at, if you keep two fingers or a pen and a finger, and you're looking at this finger, and any object in front of it is actually perceived as two. Once you concentrate on it, you can appreciate that anything in front of it is actually perceived as two. So it is sensory and motor fusion which actually enables fusion of images. So what is motor fusion? Motor fusion is the adjustment of position of the eyes. Like, for example, convergence and divergence are all mechanisms of motor fusion which enable fusion. So I will talk about instances where sensory and motor fusion gets disrupted a little later. So coming to theories, the most important theory of binocular vision, of course, is theory of retinal correspondence and disparity. So whenever there is horizontal disparity, if it is this horizontal disparity is within the limits of the Panem's fusional area, that is what enables binocular fusion. When it is beyond the limits of this Panem's fusional area, that is when you notice that there is rivalry or diplopia. So this is again based on the previous discussion on visual direction, horopter, and Panem's fusional area. So there is also a neurophysiological basis or a neurophysiological theory for binocular vision. This is, of course, based on how cortical cells perceive vision. So if you look at the visual cortex, about 80% of the neurons in the visual cortex are binocularly represented. So either in totality, for example, about 75% of these neurons can be represented almost in varying degrees by either eyes, and 25% almost interchangeably by both these eyes. So majority of the neurons are of the cortical cells can be stimulated by either eyes. So retinal field disparity is what leads to the basis. It is what forms the basis of Panam's fusional area, and this is detected by sensitive binocular neurons, which gives rise to binocular vision and stereopsis. So this is another theory behind binocular vision. So coming to normal binocular vision. So normal binocular vision has the following 3 grades: simultaneous perception, fusion, and stereopsis. So we will come to the classical examples of each. So this is a classical example, that is given in books about simultaneous perception, wherein 2 completely dissimilar images are presented, and they are fused as a single image, and this is what is simultaneous perception. So each eye is presented with a different target, and you're able to fuse them and perceive as single. That is simultaneous perception. This is the first grade of binocular vision. And the second grade of binocular vision is, of course, fusion. So here you see that they are similar images. These are not dissimilar images. They are similar images. And then these images are fused and then perceived as one, and that is fusion. So third grade of binocular vision, so you can see that this image actually gives a perception of stereopsis, but as you all know, this is just a false perception, or this feeling of stereopsis is mainly because of monocular cues rather than stereopsis. But I've just put this image because it gives you that perception of a 3D image. So the third grade of binocular vision is, of course, stereopsis. Here you find that the same image is presented to both eyes, but at slightly different angles. And this slight difference in angle, or this slight disparity, is the one that results in stereopsis. So coming to factors which impair fusion. So either the sensory fusion can be disrupted, or motor fusion can be disrupted. So sensory fusion can be disrupted because of media opacities, because of unequal image size, which can occur in anisometropia, or because of various other reasons. For example, if a patient with previous refractive error actually undergoes a large refractive error, actually undergoes a refractive surgery or a cataract surgery, again, in one eye only, then again there is unequal images. So these are all various causes for disruption of sensory fusion. There are again various causes for disruption of motor fusion. So this can occur in strabismus, which can be paralytic or non-paralytic. So if there is misalignment of the eyes, that is when there is disruption of motor fusion. Even in cases where there is no strabismus, like for example in non-strabismic binocular vision anomalies, if there is a problem in convergence or divergence, or the flexibility of switching between convergence and divergence, again there is disruption of motor fusion, and in these cases also the fusion can be impaired. A simple experiment that you can actually do to see how motor fusion is disrupted is when you look at this plus sign. If you actually press one of the eyes a little forcefully, you will see that the image moves and you're able to perceive it as double. So this slight flicker of a movement that you're actually creating by pressing on one eye or by trying to move an eye actually causes diplopia. So you can imagine that if the extraocular muscles are involved, or if the nerves supplying these extraocular muscles are involved, and if there is a gross deviation, then how much misalignment and disruption of fusion that can result in. So coming to anomalies of binocular vision, these are all various anomalies of binocular vision: diplopia, confusion, rivalry, and suppression. We will be discussing each one of them. So diplopia occurs whenever there is misalignment of the visual axis. I'm talking only about binocular diplopia. Mind you, I'm not talking about monocular diplopia here. That is out of our scope of discussion. So when there is misalignment of visual axis, that is when you have binocular diplopia. So of course, you all know how to test if it's a monocular or binocular diplopia. You ask the patient to occlude one eye and see if the diplopia disappears, and that is how you know that it is whether it is a binocular or monocular diplopia. In case of monocular diplopia, when you occlude the normal eye, the diplopia persists, and when you occlude the abnormal eye, the diplopia disappears. In binocular diplopia, when you occlude either eye, the diplopia disappears. So here, as we previously saw, if the patient is looking at this target, so imagine there is that the eye is deviated, okay, and deviated outwards. So the patient is actually looking at this. The fovea is actually projected at this target. So imagine that that this eye is actually deviated outwards. So in which case, okay, the patient will be perceiving. Okay, yeah. So patient will be perceiving this image, which is falling on the nasal retina over here in this place. Got it? So in case there is misalignment of the eyes, again, the visual direction changes. So therefore, where the person places the image in the physical space, that also varies. So the image is actually falling on nasal point of the retina in one, so fovea in the left eye and falling on the nasal retina in one eye. So therefore, there is a clear image which is formed by the fovea of the left eye, and there is a blur image. Obviously, the visual acuity and clarity reduces as you move away from the fovea. So there is a blur image which is formed on this extrafoveal point in the nasal retina, which is actually projected temporally. So this is what strabismus causes. It causes binocular diplopia, in which one image which is projected on the fovea is clear, and the other image which is projected on the which falls on the non-foveal point is actually blurred. So what is confusion? So confusion is basically perception of two different images. So imagine the brain is trying to, there is a deviation, fovea is looking, so left eye fovea is looking at the circle, and the right eye fovea, imagine, is looking at this triangle. And just imagine the brain tries to fuse both these foveal images, because these are supposed to be the principal corresponding retinal points. And of course, you know that these are very dissimilar images, and there'll be a problem in fusion, and this results in confusion. It is very rare for patients to complain of confusion. I have seen only one patient, complain of slightly something which is similar to confusion. Otherwise, what everyone perceives whenever there is misalignment is a diplopia. So these overlapping images is what causes the confusion. So what is rivalry? When there is simultaneous excitation of corresponding retinal areas by dissimilar stimuli. So this results in conflict and confusion. So what happens is sometimes there is fusion, and sometimes there is suppression. So this is basically a dynamic kind of situation where there can be fusion sometimes, there can be suppression sometimes. So only part of each image is actually transmitted to the visual cortex. So retinal rivalry, so say the right eye is perceiving this and the left eye this. So retinal rivalry would actually look something like this, wherein parts of the images from the right and left eye are actually projected to the visual cortex. So if you look at what we have to trade, so on one side, when there is a misalignment, either the patient can have diplopia or rivalry whenever there is a disparity, or they can even develop abnormal retinal correspondence. And on the other hand, they can try to suppress the image from one eye and actually do away with diplopia. So again, either whenever there is misalignment, there is either diplopia or there is suppression. So when there is a path between diplopia and suppression, that is when you see rivalry. So why do we need to know about all these principles and various terminologies related to binocular vision? Because various feedback mechanisms which are used in treatment of anomalies of binocular vision or in vision therapy, actually depend on binocular vision. So, for example, when we give convergence exercises for a patient with convergence insufficiency, we rely on diplopia for a simple exercise like pencil push-up exercise. So what we tell the patient is move your finger or pen as close to the eye as possible until you perceive it as single, and try to move a little beyond as well. And then whenever you see double, again go back, again move the finger or the pen towards you until you perceive it as double. So these are all important feedback mechanisms which actually help us or guide us in giving vision therapy as well. Blur is again an important feedback mechanism which is used in vision therapy whenever we address anomalies of accommodation, or even otherwise whenever we give treatment for a binocular vision anomaly, it always combines exercises for accommodation as well as vergence. What is lustre? Lustre is basically a simple mechanism wherein each eye is presented with different colors, and when the patient is able to fuse, they perceive a different color. So simple example is a worth for dot test, right? So you present the right eye sees red and the left eye sees green, but then when they overlap both these images, the patient may perceive it as yellow or white. So that is again some feedback mechanism which is used in vision therapy. Suppression is again something that is used in vision therapy. Localization, that is ability to localize or pinpoint a particular object in physical space. So this is again based on visual direction, based on stereopsis. So this ability is again used in vision therapy as well. Parallax is movement of the target when you actually try to move. When the person tries to move, what happens to the target? So this appreciation of this movement is actually parallax. So SILO is an acronym for small in and large out. This is again used in the treatment of binocular vision anomalies. So what happens is whenever there is convergence, right? So whenever there is convergence, when then the patient perceives the target, that the target becomes smaller and that it is moving inwards towards them. Okay, so this is again something that is used in binocular vision therapy. And whenever the patient, whenever the eyes diverge, then the patient perceives it as a larger object and they appear to move out or away from the patient. So this again, so these are all feedback mechanisms which are actually used in vision therapy. Okay, so I think I'm quite early. So to conclude, there are several advantages of binocular vision, and stereo vision and expanded field of vision are the most important advantages of binocular vision of binocular fusion. And even subtle disparities can deprive us of this stereo vision, and that is when monocular cues take over. So as you all know, monocular cues like shadows, the size of known objects, these are all subtle cues which actually take over whenever there is no binocular vision. So nobody complains. If you see in day-to-day activities, you never see that somebody complains of not being able to perform a task because they have strabismus or because they lack binocular fusion. So because in these cases, monocular cues actually take over. And a knowledge of binocular vision is actually useful in understanding various anomalies and also in treating them. So I think I'm quite, so this covers the basics of binocular vision, and we can have a discussion perhaps right now, or?
Yeah, we can have it now, ma'am.
Yeah.
First of all, I would like to thank you for the very excellent presentation, and I thank you for keeping it brief, ma'am, rather than overloading us with the information. Maybe we can deal it with the questions. Like, you have few questions, and the first one is, can you tell a single worded differentiating features between diplopia versus confusion?
Single word.
Yeah.
Okay. Okay. So diplopia, I mean, single word, is it?
Single word in the sense that they wanted something short explanation between diplopia versus confusion.
Okay. So see, I'll just explain it to you. I don't know if I cannot do justice with a single word, but I don't know. Maybe Dr. Pradeep Sharma will help in concising it in a single word, but I will just explain it to you. Say this is the normal alignment of the eyes, and say now there is deviation of one of the eyes. Say there is deviation of the right eye. So if you actually look at the foveal projection of both the eyes and the brain tries to fuse them, that is confusion. So if the foveal projection is being attempted to be fused, that is confusion. But if you look at a single object and where it is being projected in both the eyes, for example, the same, we'll take an example of a right eye being deviated outwards. Now, an object which was previously falling on the fovea is now falling on a nasal point, is falling on the temporal point in the retina, and therefore is being projected nasally. Got that? So now you're looking at the same object falling on at different points in the retina, and the way they are projected is actually different, which results in the object being projected at different points in the physical space. So this is what is diplopia. Sir, anything to add?
I think what you have said is right. Basically, both confusion and diplopia are bugbears of misalignment. So whenever there's a misalignment, these two bugbears are there. To put it, let's say, as the person is asking, to make it as brief as possible, we could say that the foveal perception is always going to be confusion. And a foveal extrafoveal perception in presence of a misalignment is going to be a diplopia. So the perception of the two fovea in the presence of misalignment is confusion. And the perception of a fovea and an extrafoveal point in the presence of a misalignment is going to be a diplopia. So if that makes it clear, because confusion is always between the two fovea in the presence of a misalignment.
Okay. I think you did justice to the single word.
Yeah, so this is a foveal versus foveal extrafoveal.
And the foveo extrafoveal, yes.
Yeah.
Thank you, sir.
How does binocular vision influence contrast sensitivity?
How does binocular fusion
Vision influence contrast sensitivity? Dr. Amitava, do you want to take this question?
I'm sorry.
Yeah, I'm not sure if contrast sensitivity and binocularity is necessarily connected, because we are looking at two different concepts here.
Yeah.
But all I can say is binocularity, like in most cases, will maybe improve by reinforcing the contrast. Two eyes may function a little better with something which they tend to help each other. Just like binocular visual acuity may marginally be better than monocular visual acuity. In that sense, I think Dr. Pradeep Sharma might add if there's anything.
I mean, there are studies which are done on brightness addition. So the brightness perception of each eye and the addition effect that you get on the brightness perception. There are several, as a research tool, this is being used, and there are good articles coming from UCLA on the brightness perception as monocularly seen and the binocular addition of brightness perception. So from that point of view, yes, contrast sensitivity would be better perceived with both the eyes. But yes, what Dr. Amitava is saying, there's a different function that we are talking about of the vision. Contrast sensitivity is looking at a different aspect of the vision.
Meenakshi ma'am, would love to have you on panel as well. So if you're online, can you please join us?
Yeah, you're muted, Meenakshi.
You're muted.
Yeah, I'm here. Unmute.
Yeah.
Yeah, I agree with you. These are different functions completely. But there are, like Dr. Pradeep Sharma said, binocular viewing. You viewing something with both eyes seems to enhance the contrast a little bit in normal subjects, maybe not as much in amblyopes. So there are some studies to suggest these that are coming out. But for all practical purposes, we consider them separately.
Ma'am, we have an interesting question. Can you explain how the 3D movies work?
How 3D movies work?
Yeah.
Okay, so basically they use polarized glasses. So each eye, just the way, I know little about, what we're talking about 3D images. So each image, each eye actually perceives slightly disparate images because of these polarized glasses. And that is what results in a 3D image. I think if anyone knows more details.
Dichoptic imagery which is being done. So two images are actually projected on the screen. There are two images, so it's called dichoptic. And one of the images having a one polarization alignment, and the other image is having 90 degrees to that polarized alignment. So these can be seen only with the particular eye. So the two eyes are given polarized filters, which are going to see the two images which are projected on the screen. So if you actually are curious, and I think you may have all done, just take off your glasses and you'll see everything is blurred. The moment they start saying, now put on your glasses, and the movies, they do this for this reason only, because the monocular viewing is no more desirable. If you have to see with the binocular glasses, and then you'll see the 3D. The other way that is being done, like in the cartoon comics, in our childhood, we used to have those comics, which were, I don't know, nowadays also available or not, but they were printed with blue and green.
Yeah.
So blue and red, sorry. So the blue and red images were there, which were again two images were there. And you were supposed to have the blue and red glasses. So these are also now coming back to dichoptic binocular vision therapy when we are doing on the television as well as in the mobiles also. So that's one strategy in which you can do the binocular vision therapy. The other is, of course, to have the Oculus-based two separate virtual reality configurement, in which you have two images which are seen by a haploscopic device. So on this mobile, you can load onto that Oculus thing, and you will see the two images. The mobile actually has two images which you can see on your mobile also if you have that. And that's another way. So there are various ways by which we are basically having a stereoscopic arrangement. Either two images are shown in a haploscopic mechanism as in a stereoscope, or two images are shown on the same screen but viewed through polarized glasses, either red and green glasses, or you may have the Polaroid glasses. The stereoscopic test, I think the next talk by Dr. Jethani will be talking about the tests for stereopsis, would be all based on these. They will be either using the anal glyph method, in which red and green glasses are used, or the Polaroid dissociation will be used. The movies are also using the similar thing.
Thank you, sir. That was a very elaborate explanation. I think we can see some happy faces, whoever have asked the question.
1 second, Asha, I just also wanted to add regarding the previous question that, contrast sensitivity and contrast sensitivity may be well preserved even in the absence of binocular fusion. So of course, like sir said, it does enhance, perhaps enhance contrast sensitivity if you have good binocular fusion. But in the absence of complete binocular fusion, contrast sensitivity can be well preserved. So it is essentially majorly a uniocular, property rather than, binocular phenomena.
The term, Asha, just one second. The term I now recall is reinforcement. When they talk about, the two eyes improving a little bit about certain facility, which are essentially a uniocular function. For example, visual acuity may marginally be better under binocular viewing condition, and the word used is reinforcement.
Thank you, sir.
Thank you, sir. What are the additional secondary visual benefits from binocularity? Meenakshi ma'am, would love to hear this from you.
I think it's additional benefits. Definitely, if you want to be an eye surgeon and a safe eye surgeon at that, and many other, I think, vascular surgery, etc. Also, commonly we will see residents struggling in their, or fellows struggling in their initial surgeries, not knowing where is the cornea or where is the posterior capsule, and then they will be rushed off to the pediatric ophthalmology, strabismology, orthoptics department to take care. So yes, while we talk about it, in a funny way, and it's useful in 3D movies and it enhances the whole quality of vision, etc. I think it is very, very important in many professions. I usually point out also a mining engineer. Apparently, a mining engineer has to be able to see the fine cracks in the wall of the mines. And so one of the screening tests they do apparently is to check for binocular vision. So yes, there are certain professions where it's an absolute necessity. It's probably even safe only if you have good binocular vision to even, get into that profession. I'd like to hear the others.
I agree with you on, the residents finding difficulty, in the operation theater. We have had some people struggling, and then when we check for, the binocular fusion or stereopsis and do a detailed orthoptics assessment, we find that they have a lot of issues, and especially accommodative issues, infacility, all these are quite common. And it's almost universal that initially when the PG start off with, they tend to accommodate a lot. They're seeing clear, and the assistant sees or whoever is helping sees it completely blur. So that's quite common, ma'am. I agree with you.
Yeah, so the reason for that, I think we had talked about in an earlier session also, the accommodative convergence is being used as a surrogate for a weak fusional convergence for these people. So when they are seeing in normal circumstances, they are using the accommodative convergence to overcome their weak fusional convergence. But when you look through the microscope, the two things are now aligned to be parallel. Then you cannot accommodate and make it any better. So all these individuals are actually having some fusional vergence weaknesses. And many a times, then once we do the orthoptic testing and then put them on fusional exercises, then they are quite okay. The other problem, of course, is the lack of adjusting the IPD. Many of the ophthalmologists are not aware of IPD. I am sometimes surprised when spectacle prescriptions are given without mentioning the IPD. And this becomes a problem in particularly children and people who have little different IPDs than most of the normal people. So if you give the standard glasses, they will have an induced prismatic effect because of the IPD causing a decentration. So another problem which will be there, again requiring a fusional vergence. So I mean, this is something which all ophthalmologists should remember, that we should be checking the IPD and also mentioning it whenever we are making a spectacle prescription.
Sir, do you think IPD measurement in prescribing to high probes especially, will it, generally we advise a full cycle of digital refraction for any amblyop. Do you think in IPD adjustment might be any problem for the people who are not really able to adjust for the hyperopia even after 6 weeks. Hyperopia glasses.
No, I mean, I didn't get your question because that there are two different things. On one angle, you are asking a hyperopic person, if he's given a glass, then it is a question of relaxing his accommodation, which is there. IPD is something which is the two eyes are having a relationship between the two. That is the interpupillary distance which we are talking about. So if that is not taken into account, whether it's a myope or a hyperope or even an emmetrope, he will have a problem. I have come across patients who have been given glasses and who have been sent to me for a squint. Actually, they did not have any squint. It was only the decentered myopic glasses. They happen to be high hyperopes or high myopes. This will become magnified. If you remember the Prentice rule, that per centimeter into the diopter power of the glasses gives you the induced prismatic effect. So it becomes very significant. And they have been with the glasses, they check, they say, oh, look, there is a cover test also giving you a deviation. The moment you take off the glasses and do a cover test, there is no deviation. It's only an induced prismatic effect. So you just correct the centration of these glasses and they are ortho.
May I add, on the contrary, as you said, this Prentice rule and the prismatic effect of glasses, again, very important when you assess patients with high refractive error for binocular vision anomalies. When you look at their, cover uncover test and everything, you can have a deviation actually masked because of that. Maybe there is an esotropia which is again covered because of the decentration, or an exotropia which does not uncover because of the decentration. So it is very important to examine these patients with contact lenses so that there is no prismatic effect. Only then will you know if the child actually, children, it may not be possible, at least for adults or older children. Then you will know if the patient actually has any squint or not, any strabismus or not.
But Sumita, you may not necessarily require to make them wear contact lenses. It may not be
well-centered. Agreed, sir.
Basically, what you need to see is the centration of the glasses and the IPD relationship. Because giving the person contact lenses, I don't know, maybe not feasible.
Yeah. I think for hyperopic patients, we tend to
just check the IPD and look for the glasses centration. Most of the time when you look, seeing the power of the glasses, also see the centration of the glasses and then check the actual interpupillary distance between the two centers.
Okay, but would it make a difference, like for example, distance and near? They won't be looking, obviously for a particular distance, they may not be looking through the center of the glass, especially when it comes to the near deviation. Do you think
they are aligned for the IPD? If they are aligned for the IPD, they would be looking through the centers of the glasses.
Okay.
No, because the glasses are supposed to be placed close, and at that point, they are supposed to be aligned with that. We are measuring the IPD also at the same distance from the eyes. So it will have to be correlated with that.
Okay.
I think what Sumita is trying to say is that if the IPD is placed for a distant view, then the central positions will be different. And when the person is asked to look close by, then he may not be looking, he can't be looking through the centers of the glasses, both at distance and at near.
Mm-hmm.
So, Sumita?
Yes, sir. That's what I was trying to tell you.
Yeah.
But perhaps the difference may not be too much, as sir mentioned, if it is, if it is not very high refractive error. But when you see very high refractive errors like say 10, 15, then that even a few millimeter, if you go by the Prentice rule, even 1 millimeter or 2 millimeter displacement there would induce a significant prismatic effect.
That's right. I mean, Dr. Sumita, that's right, that whenever we are prescribing for presbyopes, that's why they say that you can decenter the bifocal also.
Okay. Right, sir.
Yes.
A little off the topic question, just because I faced this problem in my recent practice. There was a patient who was almost 5-year-old, and she was not prescribed the correct glasses all along. So she developed an amblyopia, and she is having right eye vision of 6/12. She was going through vision therapy as well. and she was using, so before she came to me, she was already ran through 40 sessions of vision therapy with a +4 in the right eye and 0 power in the left eye, and she did not really improve even with the vision therapy. So, and when I have done a cycloplegic refraction, there was almost +6 in the right eye and +3 in the left eye. Though she was having a 6/6 vision with a little strain, not much of a strain, what do you think an adequate, like a better prescription in her case would be, because she has already gone through vision therapy? I think fully cycloplegic refraction, should we go for that? Or
who's this question for, Dr. Asha?
anyone can answer. I'm looking forward to hear it from
What is
Dr.
the,
Pradeep, Dr.
age?
Amitava, and Dr. Meenakshi.
What is the age, Dr. Asha?
4 to 5-year-old.
45-year-old, is it?
4 to 5.
4 to 5-year-old. Okay. 4 to 5-year-old. Okay.
Yeah. Dr.
The
Pradeep.
patient has a strabismus?
No, ma'am. She does not have.
Doesn't have anything.
No.
Then I would, treat her like anisometropic amblio. And I'm not sure about this vision therapy, but we know that in the absence of strabismus, or even in the presence of strabismus, you can cut off 1.52 diopters, give only glasses, give refractive adaptation, no amblyopia treatment necessary at that particular juncture. Call the patient back after 12 weeks, 8 to 12 weeks, and then go from there. So this patient needs both needs glasses, constant wear, and followed by adequate, either if cooperative, occlusion. I'm still very old fashioned. I still do occlusion or penalization before going to dioptic treatment. So that would be my approach. Anything different from the others?
Agree with you, ma'am. They have a good amplitude of accommodation, so you don't need to correct the entire refractive error. A 5-year-old will have a good amplitude of accommodation. So yeah, so probably, like ma'am said, just a +1 or how much ever minimum the child accepts in that eye. And what you have to ensure, however, is that you maintain the difference whenever you give the refractive correction for the other eye. So if you're giving it's 3 and 6, the difference is 3. So you do a +1 and +4 in the other eye. Sir, would you agree, or do you always ensure this difference is maintained?
So basically, we will go by the cycloplegic refraction and give the full correction. And in this case, this anisometropic amblyopia, which is there, we usually give the glasses first for 1 month as an optical adaptation. And then many cases will improve their visual acuity in the amblyopic eye in 1 month's time. If not, then we can give the part-time occlusion in these cases. Even penalization is going to be possible in such a case which is having a hypermetropic correction. So you can even use penalization or atropenization also in such a scenario if the occlusion is not going to be accepted.
So do you suggest we go with the fully cycloplegic refraction of right eye +6 and left eye +3?
As per the prescription, I mean, cycloplegic means you're going to cut for the cycloplegic action, yes.
After the reduction, definitely.
So as per the acceptance that you will give, yeah, sure. And as Dr. Sumita is saying, you need to maintain the difference between the two. I mean, we need not actually cut only on one eye. So I have seen people doing like prescribe +3 and 4.5 just to bring them together. So that is not a desirable approach. So you should give that full correction so that the vision is restored. 1 month you can try optical adaptation. If that is not working, then you can either do the penalization, which will give the binocular advantage, or you can do monocular occlusion.
So, but left eye, she was already having a vision of 6/6. And when I have given her a +2, her vision has actually reduced.
Okay, so that is fine. I mean, that is reduced. It is working like penalization in the initial period. If you're sure of this correction, you should give it. In a way, it is working, right?
I've tested her twice and always she came +3, +2 in the left eye, though she was 6'6", cycloplegic.
That's what I'm saying, that basically it's like fogging. She's not accepting the full correction because she's accommodating. If she's accommodating, now you have to be careful that she's not having an esophoria. People who are accommodating and not having esophoria, they may have good divergence, fusional divergences. So they may even come out with ortho in spite of accommodating. So many of these children may be doing that. So what I would say is that if you're sure of the correction that you've got on your retinoscopy, you give that amount, reducing only for the cycloplegia that you have created and the distance, of course, give the full correction. And in a month's time, they will accept. In the meantime, that the vision has dropped in the right eye, it's going to be working in your favor only, because then the left eye is going to be used and that will be improving.
Yeah, I can see Dr. Meenakshi wants to add something.
Yeah, I know. I just wanted to add a few points, or rather reinforce a few points for this particular topic, that topic of today. First, I wanted to compliment Dr. Sumita on a very nice, comprehensive, lucid explanation of binocular vision. It's a very tough thing to understand, to grasp. And because in ophthalmology, our focus has always been all the parts of the eye from front to back. And so when you start looking at both eyes together, it's very, and a lot of it is theory. So students, postgraduates usually get put off. But I think you made, with very nice diagrams, made it very palatable and understandable. My couple of suggestions I had was, one, for the students, it's increasingly the use of the synaptophore has become less and less. When I was a postgraduate, we all were trained. In fact, we were asked to evaluate every single strabismus patient on the synaptophore. But in my US training, we hardly used it. We used mostly, prisms and other ways of testing for binocularity with charts and Würth dot and so on. But if you want to really understand the concepts of simultaneous perception and fusion, as you showed, nothing better than a synaptophore. So I would encourage you to go over to the nearest medical college. Usually most medical colleges still have a synaptophore. Please take permission, especially DNB residents, go and look at use the synaptophore, and then your concepts will become really, really clear. That is one of the suggestions. Just one other point I wanted to add is that as a practitioner, or you may choose various paths as, after you finish your post-graduation, when will you really encounter anomalies of binocular vision? When will a patient come to you? Is usually with physiological diplopia. It's funny, they will come and talk about physiological diplopia without realizing that's what it is. One day they were bored and they suddenly noted that when they were reading things, everything far away, because they finally opened the book, finally everything far away started looking double. And then they come rushing, and nothing as scary as diplopia. So that is one thing you will encounter in practice. The other important thing is, as Dr. Sumita already told, sensory disruption, start of a cataract, or you have induced anisometropia by either refractive surgery in one eye, or you've removed cataract in only one eye. Any of these things will cause disruption to fusion and can result in the start of diplopia, especially if they are already a little bit compromised. This will cause precipitation, and they will come to you with diplopia. Sometimes they'll come to you with anisoconia. Will not even be able to describe it, but that they will come to you. So these are the things, even as a general ophthalmologist, as a specialist refractive surgeon, is the situations where you will encounter anomalies of binocular vision. So something to be aware of. Thank you.
Thank you, ma'am, for the great key points to be added. Just when you have said that, I remember how Dr. Pradeep Sharma sir has got a synaptophore installed in our ward itself. So our wards are 24/7. So we used to finish our work up till 8 o'clock or 9 o'clock, and then we used to make the patient, each patient sit in the synaptophore and start doing synaptophores.
What Dr. Meenakshi was saying reminds me when I had gone for my fellowship, advanced fellowship in UCLA in 2001, Dr. Rosenbaum was there, and there was a case which was of central fusion disruption, and that required a synoptophore. So Dr. Rosenbaum says that, look, we need a workup with the synoptophore, but none of us actually knows how to do it. So we will get David Kirschen, who was the orthoptist, who used to come only once a day in the week. So we'll invite him to come and say that. So he was asking me, have you used? Oh, yes, we do use synoptophore. So that was interesting. So because most of the pediatric ophthalmologists in US nowadays don't use synoptophore. It's left to the orthoptists, who are also far and few in US.
Dr. Amitava, do you want to add anything to the session of binocular vision?
Just one or 2 points that mostly binocularity is of greater importance at near. The depth perception, I'm talking about stereopsis. For distance, because the IPD relatively is much closer for distance viewing, it doesn't have such an important role. But it's also interesting to, remember that all these watchmakers, they're doing a pretty good job with just one monocle, over their eye. For years, we've seen these chaps work in small towns. That guy comes and, he manages to do everything there. He's probably using more of an alignment to put those things into that little nut and bolts into the right places. He's aligning very well. I wonder sometimes if they could get these, binocular, say, Stereopsis glasses, like loops that we use, maybe they'll be able to do a better job. But they work for maybe half a century. I've seen them from my childhood. They do a pretty good job with monocular, magnification. I, in fact, as an intern, bought a monocle at one time as an intern because I was so intrigued with this fact that, they could, and I had practiced to put it on my eye to see close by and look at pathologies, actually.
So, Dr. Amitava, I think we are having two different things. They are basically interested in magnification.
Yes.
So the monocle is basically as a magnifier. So even in the ophthalmologists earlier, they were using uniocular loop as a magnifier. I mean, it was, when we were students, it was a must that everybody had to carry a torch and a uniocular loop as students' times. So that is for magnification. But when we are talking of depth perception, there are certain jobs which require depth perception. There is going to be a problem. The same analogy, I think I will say that shooting. Now, shooting is supposed to be a very precise job.
Yes.
And you would see that most of the people who do the pistol shooting cover one eye and do it. I mean, that is the standard thing. But recently I had a sportsman who had come for the skeet shooting, in which there is a moving target at variable distance. So he is supposed to see with both the eyes, but at the time of shooting, he is going to use only one eye. So he had a very unique problem that he had a very little foria. I'll tell you, just one prism foria, which was troubling him. And finally, I mean, he took that one prism diopter as a prescription over his 0.5 diopter glasses, which he says now that makes him, I mean, he's one of the potentials for our Olympic awards also, maybe someday. So, I mean, this is difference. When we are looking for skeet shooting at distance, you require binocular vision to start with to see the aim. And at the time of shooting, then you have to just do through the barrel, which is uniocular. So there you require both the things. But the other jobs, you just keep one eye closed and you can shoot because you just have a steady target. There is no parallax, thing, and you can judge, the depth is fixed, then probably monocular viewing is fine. The same reason probably Patodi kept on playing for some time, not as good, with one eye lost.
Yeah.
So with this, because Dr. Shefali has appeared, that means it's time that we conclude the session.
Sorry, Dr. Asha, just one point.
Yes,
yeah, thank you so much, Meenakshi ma'am, Pradeep Sharma sir, and Amitava sir for all your inputs. There's a lot I'm sure that the postgraduates have learned, and I myself have learned from each one of you. And just wanted to add one point about what Meenakshi ma'am said about the cataract surgery and other things disrupting the sensory fusion. So I have seen patients coming up with a constant strabismus after monovision has been introduced. So a lot of cataract surgeons practice this monovision. So they correct one eye myopic and the other eye for, they keep one eye myopic for near and one eye for the distant vision. And this disrupts the binocular fusion completely. So a detailed binocular vision assessment or orthoptic assessment is imperative in a patient before you decide on monovision, because you're going to be completely disrupting the binocular fusion. So just this one point, if there is anybody who's going to be practicing this in future.
But nowadays they are saying they've learned from us, or maybe the patients themselves, of the problem. So now they have switched from monovision to micro monovision.
Micro monovision, exactly.
So they have reduced it to 1.25 diopters difference.
And even cylinders, I think some experimentation even with the little bit of cylinder and all that is...
That's another aspect. That's like giving an accommodative effect for that. But basically what you're saying, because we happened to do a study in RP Center, thesis was done on this monovision thing, and we had seen. So it is acceptable till about 1.25 diopter difference. That gives you a advantage of some depth perception for near, as well as you can have the monovision working for distance and near both. One eye is adapted for 1.25 diopter, and one is going to be ortho. I mean, the dominant eye should be corrected for distance, and the other eye is then corrected with 1.25 diopter more. So it's a micro monovision.
Thank you, sir.
Even in my practice, ma'am, in my cataract operated patients, with the difference of 0.75 to 1, they are doing absolutely well with binocular vision. I've checked their stereopsis as well, and they are doing quite good, just as a pre-op.
But this is, have you corrected those refractive errors, or are they uncorrected?
Uncorrected, definitely. That's the whole point.
We are happy with that. Many of them, they may not require that good stereopsis. So it will affect the stereopsis to some level, but it will be manageable. So they are okay with, but they're happy to wear no glasses. Basically, they're glasses free.
Yeah, perhaps, but all these patients that you have seen, Dr. Asha, must be having, good fusional amplitudes as well. They may not be having large forias.
Maybe.
What I'm trying to say is, if there is a large foria, which is beyond the normal limits, and then you induce monovision in such a patient, so they will not, their fusional amplitudes will not be sufficient to compensate.
Quite true.
So with this, we would like to conclude the session. Thank you, Dr. Sumita, and thank you, Dr. Pradeep Sharma, and thank you, Dr. Amitava, and thank you, Dr. Meenakshi, for joining us today. It was very interactive and lively session today. And above everything, I would like to thank Dr. Santosh for the smooth organization of this session. Next, we will be meeting on evaluation of binocular vision by Dr. Jitendra Jithani on this July 29th. Bye, everyone.
Thank you all.
Bye-bye.
Thank you so much. Bye.